Okay, well, why don't we get started while people are still logging in? Thank you for joining us this month for our teffy Grand Rounds. That is the Texas Epidemic Public Health Institute, if you were not aware of that. Today, we're going to be hearing about Chagas disease in the US, and I will introduce our speaker in just a minute, but if I could go to the first slide, please, or really the second slide. I want to just tell you a little bit about teffy. This is a state organization or agency rather that was started 2 years ago. And our goal is to keep Texans safe and the economy strong by strengthening capacity of Texas communities to respond to the next future infectious disease outbreak, because we know there will be another one. So next slide, please. So it's a state agency, but housed within UT Health. And we have partnerships with a number of other agencies, professional associations, businesses, other academic institutions, and community organizations, because preparedness takes everybody. Next slide, please. As part of teffy, we have a certificate program in pandemic preparedness and response. It consists of 4 online asynchronous courses, so you can do them at 2 in the morning if you would like to, and culminates in a tabletop exercise where you put everything that you've learned together. This is free for Texas residents, and we do offer continuing education credits. So you can see down at the bottom, there's a QR code and also a website to go to, or, and I'm sure Dana's going to put this in the chat, but it's texas.teffy.gov, and you can find out about all the things that are happening with teffy there. Next slide, please. So these are different ways you can connect with us to find out about previous webinars we've had. We also have teffy talks, which have to do with business associations and preparedness for them. We just had last week a talk on syphilis. You may have heard in the news today or yesterday about how we're seeing so many more congenital syphilis cases. You can go there and see, all of our previous grand rounds are on YouTube, so you can find the links on our website. We also have a bi-weekly newsletter called Lit Reps, where we look at what's in the media about infectious diseases, preparedness, etc., and we compile it for you, so you have a one-stop shopping to find out what's happening. Next slide. So just a little bit of housekeeping. I think closed captioning is already enabled. There is a Q&A little bubble down at the bottom where you can ask questions. You can react using Zoom. There will be a survey upon the end of the webinar, because we're, of course, want to make sure we're giving people what they need to know, what they're interested in. And that this webinar is being recorded. It will be emailed in about a week. And again, you can always go to the teffy website to find out this webinar and others. And while I am on that subject, our next webinar will be January 7th. Dr. Greg Gray from UTMB is going to be speaking on mitigating future pandemics, new threats, and strategies to consider. So you will be getting emails closer to the date about that. And I realize I should have introduced myself. I'm Dr. Kathy Troisi. I'm on the faculty here at UT School of Public Health, and also involved with teffy and head of the training division. So we can go to the next slide. Our speaker today is a friend who used to be on the faculty here at the School of Public Health, although in San Antonio, and Dr. Paula Stigler Granados. She is currently an associate professor and division head for environmental health sciences in the School of Public Health at San Diego State University. Poor thing, living in San Diego with that lovely climate. Too bad you weren't here this summer, Paula. Her main interests are Chagas disease, as you may have gathered from the talk today, global health, public health policy, and neglected diseases. She has an MS in environmental health sciences from San Diego State University and her PhD in global health from University of California, San Diego. Dr. Stigler Granados launched the Texas Chagas Task Force in 2015 when she was here at UT School of Public Health with partners from UT and Texas Department of State Health Services, the military, and several other experts on the topic. She's gained national recognition for her work on Chagas disease, and she now leads the U.S. Chagas Task Force. She's currently PI on several Chagas disease-related grants, including a CDC-funded project to raise awareness among U.S. healthcare providers using telemonitoring, Department of Defense Global Health Initiative grant to conduct surveillance of Chagas disease along the border in military communities, and a study of Chagas disease prevalence in Texas mothers through an analysis of newborn dried blood spots. So Dr. Stigler Granados, thank you for joining us today. And I think you have control now of the slides.
I do. Thank you, Kathy. It's great to see you again. And yeah, I'm suffering here in San Diego.
You missed our 105 for, I don't know, 3 months or something.
Well, unfortunately, my family's still in Texas. So guess where I spent my summer?
Oh, yeah. No, that was the wrong way to do it.
So we used to come to San Diego to summer, and now we go to Texas. So yeah, joy. No, I love it. It's great to be here. Thank you for inviting me to talk about this topic. I recognize a few of the people that are here. I did want to acknowledge Dr. Cropper, who I did see your name. I am a big fan of his. He was actually the whole reason why I started looking at Chagas disease. When I was at UT Health, he had a grant opportunity that he approached me with to look at Chagas disease at Lackland Air Force Base, where the military working dogs are housed and were unfortunately dying of Chagas disease. And that launched my career. So I'm always grateful to him and glad that he's here with us on this webinar. So I'm going to talk about understanding risk, at-risk populations, the screening protocols and challenges to diagnosis and treatment. And I recognize that some of you may have a lot of information about Chagas disease. Some of you may have very little information about Chagas disease. So I always like to approach this topic with sort of it's Chagas disease 101. And I hope it's not too basic, but I feel like it's important because it is a very complex and fascinating disease that all of us right now where we live are at risk. But we're going to talk about who is most at risk and also some of the challenges with this complicated disease. So really, what is Chagas disease? Have you heard of it before? The question I always ask people is, do you live in an endemic area for Chagas disease? If you are in Texas, right now, you are sitting in what we call an endemic, non-endemic region. So we have the bugs, we have the parasite, we have the disease, we have local transmission. However, it has not been designated by the CDC officially that it is endemic because we think we have more imported cases than we do local transmission cases. And I believe that this may start to shift as we're doing more and more surveillance. And obviously, as epidemiologists, we know the more you look, the more you find. And so all of the states on this map that you can see, all 30 states here, all have potential local transmission for Chagas disease. So there's two parts to this topic. There's the local transmission, and then there's also imported transmission. And this is where we're going to talk about the populations that are at a really high risk because of their barriers to accessing healthcare, and also because many of our healthcare providers in the United States don't know a lot about this disease. So they wouldn't necessarily know how to treat or how to screen or who to screen. I'm going to cover a little bit of that. So the big picture global impact of Chagas disease, it is quite common in parts of Mexico, Central America, South America. It is a disease of the Americas. The triatamine bug that you can see in this picture is only found in the Americas. Well, it isn't actually. We have triatamines across the world, but the ones that carry the parasite that causes the disease are only found in the Americas. We estimate between 8 to 12 million people are infected. And we estimate also 12,500 deaths annually and maybe around $627 million in global healthcare costs. The reason why there's a lot of maybes and sort of squishy numbers around this is because the majority of people living with this disease don't know that they have the disease. It was originally named after the Brazilian physician Carlos Chagas in 1909. It is not new to the United States. It is not new to the Americas. It has been around since the beginning of time of the Americas that we know of. It has been documented in the Americas in mummies that were 9,000 years old, found in South America. And it is caused by the parasite Trypanosoma cruzi. This is not something that is emerging in the United States as a problem that's coming from Latin America. It has actually always been here. And I always like to be very clear about that this is a disease that we actually have not been very focused on, but we have quite a lot of it here in the United States. We just haven't been looking for it. So it is considered to be an emerging disease of importance because as we do also have a lot of migration coming into the United States and other countries like in Europe and Spain and places where we have migration of people from endemic regions of Latin America moving into, it becomes an emerging disease of importance, especially for our healthcare providers to understand how to treat the populations that are living within their borders. And it is associated with, and I'm going to go over this a little bit more, but with congenital transmission, so mother to fetus, blood and organ transplantation. And this is mainly how we see it in non-endemic countries. So, for example, in the United States, we actually think there's probably more congenital transmission that's happening right now than any other type of transmission. We're guessing on this, but this is what we're guessing. In the United States, about 300,000 individuals are estimated to be infected with the T. cruzi parasite, but this does not include local transmission. It is based off of a model that looks at the known prevalence of people who have come from regions that it is endemic. So Mexico, Central America, South America, and we look at the percentage of people living in the country that have the potential to have that disease based off of the prevalence in their country of origin. So according to many of us, we really believe that 300,000 is extremely low and is a way underestimate of the disease burden that we have here in the United States. Again, like I said, transmission happens mainly through the vector. And this is the vector. And we're going to talk a little bit more about the vector. I break this talk down into like human, animal, and vector, just to kind of give a basic understanding. But the vector transmission is how it mostly happens. Then we have congenital, followed by sometimes oral. Ingesting the bug or the feces of the bug or any part of the bug that has the parasite within it can actually cause the disease. And we have had foodborne outbreaks of this, not in the United States, but in other countries. The triatomine is a kissing bug also for, that's what we kind of commonly refer to it as again, it's about 138 species, most of them found here. Everybody always asks me, what do they look like? Have you seen one? You probably haven't, but you might have. If you're in Houston, I'm going to show you which ones you may have seen. If you're in San Antonio, you've definitely seen some. We have a ton of them there. And we'll talk a little bit more about that, but they primarily feed at night. They're called kissing bugs because sometimes they feed around the face. They do take blood meals. And the reason why they feed around the face is because that's usually what's exposed while you're sleeping and you're breathing out, and that's what they're attracted to, your breath. And but they are non-discriminating. They will bite anywhere on your body that they can get to. I just wanted to be clear about that. A lot of people think it's only on the face, but it is not. They will also feed on anything that has blood. So they transmit the disease through the feces. And so what happens in a nutshell is the triatomine takes a blood meal, very silently and quietly injects like an anesthetic so you don't really feel it, takes a blood meal as its belly swells up. Sometimes it defecates. If the triatomine is infected with the parasite, it will be in its feces. And if that feces gets rubbed into the wound or mucous membrane, that is how the disease is transmitted. We have 11 known species of bugs in the United States. Here's our friend Gersteckerii that is mostly in South and Central Texas. And unfortunately, it is starting to become domesticated. So it's preferring dogs, cats, chickens, animals, and humans more than it does sylvatic animals. We've also got This is the Triatoma sanguisuga and the Triatoma rubida. The rubida we find mostly out in West Texas, and the sanguisuga is your friend down in Houston. And there's quite a few of them. I don't know if any of you, I can't see you right now, so I don't know if you've seen these bugs, but if you have, we'll talk about what you can do with them and what you shouldn't do with them here in a minute. Here's a couple of pictures of what a bite might look like. The one on the far right, the woman with the periorbital swelling, we call that Romagna sign. That is what you will see on the internet. It is actually because the bug bit her near her eye. A lot of people think that this is a sign or like a symptom of the disease itself, but it's only if you've been bitten in or around or near the eye. This poor guy on the left, he got bitten several times on his back while he was sleeping. And then the arm in the middle is just to kind of show you that there's no real specific looking bite. It's very non-specific. A lot of people ask me to look at their bite and, hey, do you think this was a kissing bug bite? And it's really difficult to tell. There's 3 phases to Chagas disease. You have the acute phase, you have a chronic phase, and within those chronic phases, there's 2 phases. You have asymptomatic, latent, indeterminate is what we call it. And then you have the clinical determinate phase. And this is usually whenever people start to develop heart or digestive problems, which are irreversible and often fatal. This indeterminate phase can last a year, 10 years, 20 years, or could be forever, depending on the patient. We don't actually know why some people go on to develop the determinate form of the disease. But this is a graphic display of how it progresses. You have that acute phase, which is about the first 8 weeks. It's important to note that during that time frame, it's the acute phase. It's really difficult to diagnose during the acute phase. Most of our testing that we have available right now is based off of antibody testing. And so you have to wait those first 8 weeks before you do confirmatory testing, unless someone is acutely ill. And we have diagnosed 3 acute cases in the US. I think they were all from Texas. Of maybe one was in California, but at least 2 of them have been in Texas, where a patient presented very ill and they were actually due to PCR. And actually one of them did some genetic screening and DNA screening on them, and they were able to determine that they had acute Chagas. Most of the time though, we catch it in the chronic phase. Most of the time we actually catch it during this indeterminate form, which is when we want to catch it, when there's no symptoms. And the number one way we find out is people donate blood. So people donate blood. First-time blood donors do get screened. They get this letter that says, hey, you've tested positive for Chagas, talk to your doctor. And this is where we run into some barriers that I'm going to talk about in a minute. About 70 to 80%, we guess, remain indeterminate throughout their life, but can reactivate if they become immunocompromised. But 20 to 30% will progress if it's not treated into the determinate form. And it causes basically Chagas cardiomyopathy, in some cases gastrointestinal disease, but we think that the GI illness is more related to the South American species, but that's not completely accurate. It could be both, but we see it more often with the cardiomyopathy in the United States. So that's the basic gist of the disease there, but I'm going to talk a little bit about prevalence of disease in the US, which we don't really know a lot about. I mentioned the study that shows the model that shows maybe about 300,000 Latin American born residents in the United States, we estimate have this disease. However, we don't know about local transmission, autochthonous cases. We have no idea. We are finding more and more. I have some data that I'll show you in a minute about Texas, where it is reportable, and our zoonosis team, the DSHS, are doing a fantastic job with tracking this disease as best they can. And because it is reportable, we have found around 30, I believe 38 cases of local transmission in Texas. Again, if you're in San Antonio, we've got a lot of stuff going on there. I would just urge you to pay close attention to this. It may be very important for you. So by states, we're just going to rank these states of how we look at the dispersion of foreign-born Latin American residents. California having the highest, so we have probably the highest prevalence of the disease here. Texas right behind that, then followed by Florida and New York. Again, this does not include any persons that are undocumented and or local transmission. So these numbers, again, are quite low, but they are definitely affecting our population, especially our immigrant population that is at really high risk and also has very little access to healthcare resources. And so we're very concerned about that population and making sure that they get the care that they need. Here's the slide I was telling you about. Because it became reportable in Texas in 2013, they've been tracking it. 203 cases reported between 2013 and 2020. I hope we get the new data soon. I know 2020 was a tough year, and probably numbers went down. I don't know. I'll have to talk to Bonnie Mays over at DSHS and see where we are. But if you can look at this, about 18% of the cases in Texas were local transmission, 51% imported, and 31% we have no idea. But the potential is there for pretty much anyone to be exposed, depending on where you live and how you live. So looking at the bottom of this data, we've had 3 acute cases, 153 chronic indeterminate. So those are the ones that were probably blood donations, and then 47 unfortunate chronic symptomatic cases that probably are being managed or people have passed away from. And these, again, I want to just say again, and I'm going to reiterate this, these are very, very low numbers. Of what we know. I should say that, of what we know. I believe that there's quite a bit more. This was a study that was done in 2006 looking at a survey of blood donors in Southern California, and it was found that 1 out of every 2,000 blood donors potentially had Chagas disease, kind of comparing that to HIV prevalence of 1 in 7,500 donors. And then the study looking at it as they limited it down to individuals who lived in if limited to individuals who had lived in Latin America, the prevalence of those blood donors was about 1 in 200. So kind of putting that in perspective and looking at this map of when we were tracking positive cases through a tracking website through blood donations, you can see that these are kind of spread out across the country where people were testing positive. And this is just really to show that these are the places where we hope that our healthcare providers are very well educated about Chagas disease treatment protocols, because they probably are seeing patients that have Chagas disease and they may not know what to do about it. This is another paper that came out by Amanda Irish and colleagues, Dr. Byrne, Dr. Whitman, and they were just looking at estimating this prevalence based off of these modeled numbers. I believe that they used the PUMAS data from the census, estimating about 287,000 people, Latin American born, have Chagas living in the US. 57,000 probably have Chagas cardiomyopathy and don't know that they have it. So this is also talked about a lot with cardiologists, that they're probably seeing patients that have Chagas disease and don't know it. And that we estimate 108 annual births of T. cruzi infected women and congenital infections. So the burden is out there. We know it's there. This is the lowest end of it. But we're trying to hopefully work on increasing our screening programs, who we screen, who's at highest risk, and how we can address the problems that we're having with the lack of awareness with providers. But before I talk more about human prevalence, I always think it's important to bring in the animal prevalence, because one of the main things that we've found out is that when dogs start testing positive, people start paying attention. So in Texas, canine Chagas disease was reportable from 2013 to 2015. And during that time, more than 400 cases were reported, and it was deemed that Chagas disease is endemic in canines in Texas. And so it is no longer needs to be reportable, but we are definitely still trying to track it. I'm doing something similar out here now in Southern California, where we started testing shelter dogs. And unfortunately, we've found a higher than 30% prevalence rate in our samples that we've been testing, kind of opening up a door to show that in California, where it is not a reportable condition, it would really be beneficial for us to have it become a reportable condition. We're working on that now. So with dogs, it was first found in 1972. We don't fully understand the role of domestic dogs in that transmission cycle. They could be good reservoirs for passing the parasite on to the uninfected triatamines, but we don't really know. And places like Texas, we've seen seroprevalence from 3.6 to 57%. I literally yesterday was thinking about my dog that passed away 13 years ago of an enlarged heart after I moved to California and from Texas. And it dawned on me, most likely she probably had Chagas disease. So we are seeing a lot more canine Chagas, more than people would really like to see. And there's several veterinarians in Texas that are doing a great job with developing some treatment protocols and some screening tactics that are underway right now. T. cruzi infection has been reported in more than 150 species of mammals. So just so you realize, there's a lot of infected animals out there. Here's just a little data that was coming from our colleagues with Dr. Roy Madigan out in Spring Branch, Texas. They are looking at a registry they're looking at prevalence. And we're basically saying that Chagas disease is the next heartworm of the 21st century. So you see a lot about heartworm disease. It's extremely important, but we actually think Chagas disease is more prevalent than heartworm. So just kind of putting, if you're pet owners, you know what I'm talking about. You have to spend a lot of money to give your dog's heartworm tests and medicine. We don't have a vaccine or a preventative for Chagas disease yet. Hopefully that will be here one day. Covering just a little bit about the bugs, I'll go through this pretty quickly. Again, these are those 30 states where we do have active triatamines. In Texas, about 54% of the triatamines that were collected were infected with T. cruzi. So not every triatamine is infected, but pretty high percentage. We're seeing 50 to 60% of most of them that we're collecting in Texas. Some species have more prevalence than others, but sanguisuga and gersteckeri and rubida, the ones we're seeing, those are the ones that are mostly have the higher infection rate. They are mostly for the entomology nerds that may be out there, the TC1 and TC4 are the main discrete typing units that we're seeing in triatamines. This is important though, because the diagnostic tests that we have for humans were formulated in Latin America and South America mostly, and they used different discrete typing units to formulate their testing diagnostics. And so we're struggling a bit with our diagnostics here in the US, and a lot of physicians know that as well. I always throw this in. Do you really know what a kissing bug looks like? Because I bet some of you are thinking, I've seen one of those before. There's 11 species, but there's a ton of lookalikes. And being from Texas, I've seen many, many lookalikes, and I get lots and lots of people sending me lookalike photos. So I'd just like to put this in there. The distinctive feature about them is that they have a cone nose, very skinny, and a very tiny little hook under their nose, the proboscis, as opposed to one of those assassin bugs that has a really big hook. And by the way, a kissing bug bite does not hurt. So if you felt a really painful stinging bite, most likely, thankfully, it wasn't a kissing bug. I think Kathy mentioned I have a couple of projects going on right now. I just thought I'd mention that I do have a cooperative agreement with the CDC, looking at educating healthcare providers on Chagas disease. We're doing echo sessions. Similar to these webinars, we bring in experts to do a telementoring, physician-to-physician training on the disease. We have the task force, and I have several other research programs underway right now. So that was a lot of information. I wanted to kind of jump into barriers to diagnosis and treatment, because I feel like it's these challenges to this disease that we're kind of trying to find solutions to bridge the gaps in knowledge, and really could use the support of all of our public health and medical community to address some of these issues. I had mentioned diagnostics. Testing is complicated. To give an update on where we are in testing in the United States, we used to have a couple of hemogen-based ELISA tests that required at least 2 to be confirming of the disease, and you had to get the third one actually from the CDC to confirm, because our testing diagnostics here were so poor. But due to some funding from the Mundo Sano Foundation and Exceltis, they were able to bring in from Argentina a new test kit that's been FDA approved and is much, much better at testing for Chagas disease. And we're noticing that Quest and a couple of the other larger laboratories are starting to use it. So we're having a little bit more confidence in our testing. But regardless, you don't want to treat a patient with the treatment protocol if they're deemed positive without knowing that they have confirmed positive, because we do have a lot of false positives. And so the CDC tests for free, but you have to go through your local health department. So for example, if a person tests positive on a blood donation screening, they get that letter, they go to their doctor will have to send out another blood test to a commercial laboratory. I recommend the ones that are using the Wiener test kit is the one that we're looking for. They do an IgG test. If that comes back either negative or positive, another blood sample has to be sent through the state health department that goes up to the CDC for confirmation. All of this can take weeks, sometimes months. It's pretty freaky to get this diagnosis. Nobody really likes that. We do have some rapid blood tests. You can see these lateral flow tests I have pictures of. There's some positives here. However, there's a lot of false positives with these. And I should take note too that the ortho ELISA test that we use for the blood donation screening also is very sensitive, not as specific as we would like, and it does result in a lot of false positives. But we don't recommend people thinking it is a false positive, because if you get a positive on any Chagas test, you should follow up with getting confirmed, and that will mean 2 more tests at least to get that done. So again, diagnostics are complicated. We definitely don't recommend blood donation testing as a way of diagnosing Chagas disease, again, for the same reasons I just mentioned, but a lot of people do that. Texas State Health Department is amazing, and they have this new program where you can submit blood for testing and they will test there. We still will confirm, but a lot of people who are having a hard time getting testing done through their doctors or through other ways, this is always the question I get is, how do I get tested? Your doctor can help to send a blood sample over to Texas State Health Department, and they can help run those samples. So complicated. Doesn't help with some of these barriers. Treatment. There is treatment. In 2018, benznidazole finally got FDA approval in the US. It is only approved for use in children under the age of 12. However, it can be used off-label for adults. You have to get a prescription from a doctor, and you have to be monitored. Whenever you get a diagnosis, for example, of Chagas disease, the first thing you want to do is get confirmed. If you get confirmed, then you can talk with your physician, probably get recommended to infectious disease specialists, but we're hoping that we can get primary care providers on board with being able to do this. But you would want to get an EKG to make sure you don't have any cardiac problems, probably a barium swallow to make sure there's no GI problems. If you don't have evidence of disease of the symptomatic Chagas, we would recommend you for treatment if you're around below the age of 55 and you're relatively healthy. And I'll bring up why there's an age limit here. But you would be prescribed benznidazole, nifurtimox, one of the two. Benznidazole is usually our preferred one. And it's about a 6-week treatment. It costs about $40. It's not expensive, but you have to be monitored. Your kidney and liver functions have to be monitored while you're taking it. It's not just like take a pill and be done. There are significant side effects that can be associated with the drug. So therefore we require people being monitored and it being closely watched. So once a person is treated, there is no test for cure. So lifelong regular cardiology checks are necessary. And I think that's basically with the treatment protocol. A lot of questions I get asked about this, but 55 and up, the reason why we don't necessarily recommend that is due to a large study called the BENEFIT trial that was conducted on older patients and patients that had already developed some cardiac symptoms or GI symptoms, found that it was irreversible and that benznidazole did not help with the treatment. And because it's a bit of a harsh drug, if you're over 55 or 60, you probably will never go on to develop symptoms. And so it's not necessarily recommended for treatment, but that's something that should be discussed with the doctor. This is a neglected disease in the United States. It's received very little attention from the US healthcare system. A lot of people believe it's just primarily a disease that happens in Latin America. I hear over and over again, oh, it only happens if you lived in a mud hut with a thatched roof. I have seen these bugs in $1 million homes in the hill country. It is absolutely not necessarily a disease that happens only in Latin America. We do consider it to be a disease of poverty because definitely if you have poor housing, bugs can get into your house more easily. You have more chances of being exposed. We really do believe that, it's not a one and done. You don't necessarily get exposed the first time. I always say the stars must align. The bug must be infected. The bug must defecate. You must scratch that into your wound. So it doesn't happen like generally for the first time a person comes into encounter with these bugs, but if you live in a place where there's a lot and you're a lot of exposure, there's more potential. A couple of actions needed to strengthen our health system to scale up diagnosis and treatment. of Chagas disease in the US, I worked on this paper with a good colleague, Dr. Colin Forsyth, to come up with what are some of the barriers and some of the actions that we could take. I like to bring these up because I think that they are important pieces of where we're going with this, and especially in Texas, where we know we have this disease, and we really need to be doing a little bit more surveillance on this. But limited knowledge of that disease burden, action, more studies. Fewer providers offering treatment. We need to have a statewide or national network of providers, which actually my wonderful colleagues in Houston, Eva Clark and Jill Weatherhead and a couple of other people, Dr. Whitman in California, have been putting together the U.S. Chagas Disease Network. And if you Google that, you'll find a website that pops up with the map, and you can highlight some areas and find physicians that know about Chagas disease, and you can contact, or as a public health person or as another physician, you could contact them for more information. That low provider awareness, we just need more health education and protocols for providers. So more CMEs, more workshops, more understanding these telementoring process, which we're working on. We have, I'm going to highlight this, low patient awareness. So a lot of people don't even know they have the disease. And so educating them, we have a community health worker curriculum that's underway right now with our area health education centers in Texas, working on educating our community health workers on the topic so they can take this out into their community. An absence of screening programs. This is a little bit tricky because you don't want to go out, say, to a church group and start screening people and give them a diagnosis. Because unfortunately, one, if you're doing rapid screening, it's a high false positive rate. But two, those people may not be connected to care. And so this kind of harkens back to our beginning days of other like HIV testing and things where we were testing people, finding that they were positive, but that we didn't have the facilities or we didn't have anything in place for them to necessarily go to get the care and treatment that they needed. So we need more routine screening programs, but embedded in our federally qualified healthcare systems where we know that people can get access to care. That's been really difficult to get our FQHCs on board with this testing as well because of their limited resources. The diagnostic capabilities we talked about, we need improvements there, and then also access challenges. So maybe using mobile clinics, maybe using telemedicine for people living in rural Texas. Their primary care can call in, do some telemedicine with an ID doc in Houston. Really, lots of innovative solutions out there. We just need to put them in place. Part of the model that I came up with for our Texas Chagas Task Force was really aimed at healthcare providers. How do we get them this information? As public health professionals, we're always talking about prevention and, sharing our message, but healthcare providers are very busy with their clinical practice, and they're very worried about obesity and diabetes and tuberculosis. So one more thing was a little bit difficult to target them for, but working with these groups like you all, veterinarians, pest control people, professional associations, getting the word out that you should be on alert for this bug and this disease. That's the model that we've been following. So using a One Health approach has been really important for us. Environmental health, understanding the human health connection, the animal health connection. I have this dream that veterinarians, when they test a positive dog for Chagas disease, that they provide this letter to the client that can take to their doctor that says, my client's dog tested positive for Chagas disease. Would you please test them and their family members that live in the same house with that dog? And here's the testing protocol that you want to follow. In my dreams, this will happen. I'm working on it. And if anybody has ideas how to make that happen, I will 100% work with you on that. Education and outreach for the public. We've got a couple of guidebooks out there. If you go to the Texas State Health Department website, you can find under resources this guidebook we put together when I was at UT Health. It serves for general education of the disease with the public. Here's a little bit more information that we're trying to put together for healthcare providers. And here comes the big question. Who do we screen for Chagas disease? And I get this question a lot. We put out a paper, we being the collective Chagas subject matter experts in the US, on a recommended protocol for screening and testing and treatment of Chagas disease, because there is not an adapted clinical practice guideline yet, which we would love to have one day, but we don't have one for now. So these are who we recommended to screen. And I'm just gonna kind of pop through these real quick. Any first generation or second generation people that were born in Latin America, Latinos, Latinas, newborns, or children of any person that has tested positive, so seropositive women. Family members of affected patients with Chagas disease. We also find that domino effect where the one mom tests positive, then one of the kids tests positive, then the tia tests positive, or the uncle tests positive. So family members, we always recommend because they've probably been and had similar exposures. Blood and organ donors, believe it or not, we weren't doing a lot of this before with organ donors, but now we're doing more and more of it. So definitely testing there. First generation Latinos, Latinas with any unexplained cardiomyopathy, stroke, arrhythmias, or abnormal EKGs. Your patient, if you're a cardiologist, your patient comes in, they're from Latin America, first generation, definitely want to think about screening for Chagas disease. First generation also at increased risk of Chagas reactivation. So if they're HIV or a transplant recipient and they're from Latin America, consider doing a Chagas test on them. Pregnant women having lived in an endemic area. And I'll say that again because I said Texas was endemic, not endemic. So pregnant women having lived in an endemic area, does that mean we should be screening all of our Texas moms? I will say yes. I'll just come out and say it, yes. But I also understand targeted screening is a better tactic if you're doing epidemiological surveillance. So pregnant women who you think may have had a higher risk, absolutely. History of living in poverty or substandard living conditions in an area with triadenine activity, that is anywhere in Texas. I'm just gonna, and any other place where you might see substandard housing conditions where we do have this activity. Anybody who recognizes kissing bugs, but remember there's a lot of lookalikes, so take that with a grain of salt. Question mark, people with Chagas positive dogs, maybe. That's a potential. Dogs eat the bugs, though. I just want to say that they live closer to the ground. They're outside. They eat the bugs. Much, much, much higher rate of exposure, much higher prevalence. However, if you're living with your dog and you're living close by, it means you're living close by to triadenines that are potentially able to transmit the disease. So this is a wrap up sort of. I'm coming to the end so we can have questions, but barriers to treatment access in the US, we always know we have a huge problem with uninsured patients. So there's a lot of structural issues. Maybe people's immigration status might keep them from being able to access care, income disparities, low access to health care. Then we have the systemic problem of provider awareness, the lack of public awareness, lack of routine screening. I already discussed the clinical issues with diagnosis, no test for cure. And this is also a very stigmatized disease. So thinking about this, nobody really wants to hear this diagnosis. And on top of that, to find out it's this strange disease that is associated with poverty, and being very respectful of that psychosocial, emotional, and stigma piece of this disease is incredibly important. A little bit about that impact from that low provider awareness. I just wanted to bring this up because I think it's important. Dr. Sheba Mamandi was the one that provided this information, and she's from UCLA, but she said, patients who test positive for Chagas disease through blood donations really have a difficult time initiating treatment because they have a hard time finding a provider that knows how to treat them. Primary care providers and others don't screen at-risk patients for Chagas disease. 99% of Chagas patients in the United States are undiagnosed. We think only about 1% of the people living with Chagas disease in the US know that they have it. Providers sometimes also encounter difficulty getting approval for procedures, getting the test done, working with health departments, and it's definitely not considered a risk factor, even for at-risk patients who exhibit classic cardiac involvement. I just went to the American Society for CHOP Med and Hygiene conference in Chicago a few weeks ago. A good friend of mine, Dr. Rachel Marcus, cardiologist, gave this talk, and she said, patients are walking into cardiac clinics she can look at it and be like, Chagas, this is definitely Chagas disease. I have no doubt it's Chagas disease. And another cardiologist is like, I don't see what you see. So that lack of awareness, even amongst the providers that are the specialists, we're really struggling with. So I had a doctoral student, Dr. Jerry Pacheco, who is from UT Health. He also did his dissertation on suspected misdiagnosis of cardiac Chagas disease in heart patients in Texas and found the numbers to be quite high. Making a difference, though, there's always try to throw that positive message at the end. Collaboration, super duper important with multidisciplinary collaborations. I've always felt strongly about putting those efforts and strengths into synergizing things that saturate the field with Chagas information. So thank you for letting me talk today. Hopefully I'm making some more Chagas champions out there that will take this message further. Targeting primary care physicians and veterinary practice for those screening efforts, and using things like this community health worker promotora models, the telementoring echo models, that way that we can get further and deeper into the communities. I will have to say we do have echo sessions that we put on, those telementoring. They're called ECHO. Education for Community Health Outcomes is what it stands for. We have a couple sessions coming up in November, December, January, and February. So I can give you more information about that. But basically, Chagas disease is one of the many neglected diseases that we need more attention on in the United States. So improving surveillance and education is important. And some of those global collaborations are also important to understand what's working in those endemic regions, how have they been dealing with it, and how can we take lessons from them on this. Lots of people to thank, especially my CDC partners, and my DSHS partners, which I don't know if any of you are on, but I absolutely adore working with you all, and tons of people in Texas that we work with and abroad, and here now in California. I'm taking my message across the South. So I don't know if we have any questions or if I should stop sharing my screen. What happens next?
Sorry, we do have questions. But I had one for you first. I'm going to take the moderator's prerogative. You mentioned a bunch of people who you would recommend screening. How often do you screen? Is it like hepatitis C where once in a lifetime is enough without specific risk factors, or?
Yeah, that's actually a really good question that we don't know the answer to yet. I am starting to recommend, I can't seem to get to that slide. There we go.
Yeah.
Depending on the person, depending on the population, I have told people we're mulling about this amongst ourselves every 5 years. So if you're pregnant or wanting to become pregnant, do it at prenatal screenings. Absolutely. Every time, every baby, I would recommend that for, especially if you live in places where we have a lot of triatamine activity, because you could have gotten infected between babies. And then also, yeah, if you're living in a pretty hot spot of activity, I'd say every 5 years would be a good number. Because I mean, if it's asymptomatic and you can catch it, that's the thing is if you catch it before you develop symptoms, it is treatable. But if you wait too long, it's not. So if about 10 years is the average, some people develop symptoms in 1 year. By the way, you can also have sudden cardiac death from this disease, unfortunately. And so it's not something you mess around with. We've had patients that have just had it, no symptoms, drop dead. So we don't want that to happen either. So screening about every 5 years, I would say. Great question.
All right, Rosalia, I don't know if you knew her when you were here, but she has a number of questions for you. Are these bugs susceptible to regular household bug sprays?
Yeah, I do remember Rosalie. It's good to see you. I think we're friends on Facebook too, so I get to see you sometimes. Yeah, they can be, but there's pyrethroids. I don't like them either, but I hate kissing bugs more. So yeah, I spray, but we think that the pyrethroids are pretty effective, but they do fly as adults, and so they can pass over those barriers. Just like those giant cockroaches, no matter how much you spray, you still find them in your bathtub. Very similar. And if you can find the giant cockroaches in your house, you all know, if you're in Texas, you know what I'm talking about. You can find these as well. So yeah, I'm looking at our questions right now, Kathy, if you want me to just.
Yeah, well, let me just say that coming from the Northeast, the first time I saw one of those roaches fly, I still remember.
Yeah.
It was a very traumatic experience.
I think I grew up with them, so I don't even think about it sometimes, but yeah.
Yeah. Her next question was about vets testing. You said 150 species. Does that include cats?
Oh yeah, cats have them. Cats can get it. They get it less, you know why? Because they play with the bug instead of eating it.
Oh,
If
yeah.
you have a cat, you know.
Yeah, I have a cat, yeah.
So dogs just eat it, because I didn't know this, but I recently found out that the bug tastes good to dogs because it smells like blood. So if you can imagine, it's got this nice, deep, irony, bloody smell after it's taken a blood meal. And so they just chomp it down. Cats, not so much. Dr. Roy Madigan just gave a talk for us on our echo session. He said he had a cat that passed away from it. They can't test. The Texas veterinary labs do test. Texas A&M also tests. Dr. Sarah Hamer at Texas A&M has been leading a lot of efforts on testing. So yeah, they're not cheap, but I do know that like Dr. Madigan, for example, is working on a lateral flow test that would be a quick rapid test that would be fairly inexpensive, but it is not FDA approved yet. It's just out now for under clinical trial or trial.
Let me go back to Rosalia's questions, but there are some on the chat. And you answered the first one about cats. And Vanessa wanted to know about if you think you've been bit by one, what should you do?
Great. If you think you have been bit by one, and it's been a couple of things. One, search your house. If you can find the bug, that's always the best thing you can do, because you can send that in to the Texas State Health Department for triadenine bug testing. Go to their website, Google Texas DSHS Chagas, and it'll have a link for triadenine testing. They will send it off to the CDC, test the bug for the parasite, and if it tests positive, they will test it for what its last blood meal was. If it tests positive for humans, they'll get back to you and say, let's go get a test from your doctor. Preferably, you want to wait those 8 weeks so that you have a chance to build up the antibodies and then seek out testing and possibly treatment. It's a process, though. And I've had quite a few people that have had their kids been bit and really freaks them out. And so that waiting time, there's some mixed messages out on the internet that says it's not treatable once it's out of the acute phase. That is absolutely not true. It is not treatable once you've developed the longer term symptoms, which could take a decade or more. So although living with the parasite is terribly frightening, it's not something that you have to move on extremely quickly. However, definitely would want to submit the bug, but if you don't have the bug, talk to your physician and advocate for yourself. And if worse comes to worse, email me and I'll get on the phone and call them myself. And I do it all the time. Because if you think you've been bitten, there's nothing, and you live in Texas, there's nothing wrong with requesting this test at all. And I hope more doctors will be willing to do that.
I just want to clarify, you're saying there's misinformation on the internet?
I get that all the time. People are freaking out. They're like, I can't wait 8 weeks. I have to get treated right now. And because of that, their blood donation screening test that tested positive, I've had 2 people now convince their doctors to start them on treatment. And I have asked them to get confirmation, and they have both not confirmed positive, although they were taking treatment. And so we do not want people to start treatment. In the past, you could only get the drugs through the CDC, so it had to be confirmed. Now that you don't have to confirm it, a doctor can prescribe it, but we don't recommend it. Don't take it prophylactically, like you got bit, so I'm going to start taking it. This is not a drug to mess around with. You don't want to take it unless you're 100% positive that you are indeed infected. I want to answer Rosalia's question about the certified training for CHWs.
So let me just preface that, because Rosalia is our CHW guru, as you know, and has been developing a number of trainings for CHWs for teffy. So this would be a very good partnership.
I would love it. And I think her and I talked about this many years ago. We have a DSHS CEU certified Chagas training. It's done in a 4-part series online. And I'm going to be coming to Texas to test out the in-person 8-hour, 6-hour workshop. It's I think it's for 6 CEUs for CHWs. And I work with the South Texas Coastal AHEC to do this, but all the AHECs come. So we've trained quite a few promotores already. And I am working on a national curriculum that the CDC, I hope, will certify, and there'll be a train the trainer program. And I would love input on getting that to the table. The CDC is part of my grant, so they want this to happen. And I am not a CHW, I'm not a community health worker, so I need you all to help me with that. So if you're ready, I'm ready. I've got a half-written curriculum that's been piloted, and we're ready to do it. So yeah.
Great. I'm sure Rosalie is going to be in touch. Speaking of which, someone else had asked about getting your email, which I can't get because my email isn't up, because you know, in case they want to talk to you.
There we go. There it is. P. Stigler Granados at scsu.edu. I'm also at PS Granados at txstate.edu.
Say that slower. Oh,
Yes.
wait, I gotta check. I gotta change this. Okay, go ahead. Actually, are you seeing the chat? It'd be easier for you to write it in.
I could put it in the chat. Is it the Q&A or the chat?
The chat. That way everybody can see it. I don't know. Maybe they can see the Q&A too.
Can you all still see my screen?
Oh, it's right there. Yes. Thank you.
There
You don't have to put it in. It's right on the screen. Yeah.
There you go.
I did confess to Paula that I'm very, very jet lagged, having returned from Europe last night and up at 2 a.m. because my body thought it was morning. So I'm duller than usual today.
I understand. There was another question about the rapid test kit costs for NBIOS, which is an FDA-approved rapid test kit. They run anywhere between $8 to $15 for a provider. Depends on how many you buy at a time. But yeah, again, I have research rapid stat pack test kits that are not FDA approved that I pay about $6 or $7 a piece for. We've heard that the lab testing for the recombinant DNA, the Wiener testing at Quest, can run anywhere from about $100 to $200. Cafera Labs is the newest guys that have come on board, and I am excited about them because they're up in Boston. Cafera Labs is CLIA certified, and they can now test and confirm, which is amazing because they have 2 different tests that they can use, and then they have a third for confirmation. So we're looking to them, but they're a little bit pricey so far. But I think they're going to be a really great resource. They just came on board about a year ago.
Great. Thank you so much. We are out of time. Do you mind advancing to the last slide?
There we go.
Yeah, with this information again for everyone. You can find it all at teffy.texas.gov or this QR code. So thank you everybody for joining us. Thank you, Dr. Stigler Granados. The webinar will be sent out, as I mentioned, in about a week. It will go to everybody who's registered. So thank you for joining us and see you in January.
Thank you.
Bye-bye.